Good afternoon and welcome. It's so great to see everybody again. I'm Patrick Flume. I'm from Charleston, South Carolina, and one of the co-chairs for this session. And today we're going to talk about models of care. This obviously has been a hot topic. We received an enormous amount of feedback from all of you, as you will soon hear, and we've tried to be responsive to that. So I'm just going to kick it off very quickly, first by introducing my partner and co-chair in this, Rebecca Brown from Vanderbilt University. Rebecca obviously knows she was chosen for this role, but I have to say it has been an absolute pleasure to work with her. This is the first time I've had that opportunity, and she has been consistently responsive and shown a tremendous amount of leadership. And so she's going to kick us off. So, Rebecca.
Thank you. And welcome to the symposium about the new model of care. The opinions expressed today are not necessarily the views of the Cystic Fibrosis Foundation. I'm going to start off with an introduction, basically setting the stage for an evolving CF care model. So I have no direct financial relationships to disclose. I do want to mention that as an interdisciplinary team member, my role could be influenced by the position papers and the interim guidance discussed today, as is true of all the team members on the committee and presenting today. So why do we need to change now? We have had a few factors that have influenced CF care in the United States over the past several years. In October 2019, as you know, elexacaftor, tezacaftor, ivacaftor, or ETI, was approved for ages 12 and older. This FDA approval has now been expanded down to 2 years of age. While not everybody responds the same way to modulators, we do know that the approval of ETI expanded the number of people in the US who are eligible for modulator therapy. Following close behind, the SARS-CoV-2 pandemic changed medicine not only in the US, but worldwide. As the US went into lockdown, CF clinics rapidly transitioned from in-person visits to telemedicine. The necessity and desire to approximate the same level of care virtually as we provide in person catalyzed the advancement of technology for remote monitoring and virtual medical care, and paved the way for alternative methods of healthcare delivery in the future. Through the past several decades, lung disease in 18-year-olds has improved. As you can see, the normal lung function, represented here in green, and mild lung function, represented here in yellow, has taken up a bigger chunk of the pie in 2023 compared to 2013. But you can also notice that throughout the years, lung function has improved all along. In addition, we have seen some improvement in lung function in adults with CF. As you can see here, lung function, the median lung function, or FEV1, is noted in red, and the mean values are noted in blue. You can see that the improvement has been more drastic over the past several years, since 2019. In addition, the difference that's noted between the mean and the median curves demonstrates that while many have experienced improvements in outcomes, heterogeneity remains in the clinical status of adults with CF across the US. This notes individuals tested with IV antibiotics for a pulmonary exacerbation over the past several years. In green are people who are birthed to 11 years of age with CF. In light blue, 12 to 17, and the dark blue are our adults, 18 years and older. You can note that there's been a steady decline in pulmonary exacerbations, and more drastically between 2019 and 2020. However, we have reached a new steady state from 2021 to 2023. The location of our CF care has also continued to change. You can see the steep decline in the blue curve, which is the in-person clinic encounters, and a steep uptake in the telehealth encounters starting between the first and second quarters of 2020. However, after the pandemic lessened, we have a rise in in-person clinic encounters and a decline in telehealth encounters, but we never reach pre-pandemic levels for either of these measures. This chart shows the average number of exacerbations per person with CF in the US. The green bar are telehealth encounters increased drastically in 2020, as was noted on the previous slide. However, over the past couple of years, we seem to have reached a steady state with telehealth taking up about 20% of encounters in the US. What's interesting is the number of overall encounters in 2023 increased in the US. However, due to the rise in the population of people in the CF, the number of individual encounters per person remained the same. This graph shows pulmonary function testing, which is and the number of cultures that are frequently performed during in-person visits. In blue, you can see the number of lung function, and in red or orange, the number of respiratory cultures. While individual testing has decreased compared to pre-pandemic levels, this does appear to be leveling off and is not further declining. The nature of testing has also changed with a decline in sputum producers. Sputum is noted on this graph in blue, and throat or nasal swabs or oropharyngeal swabs in red. Since 2019, the percentage of sputum in diagnostic tests has dropped from 80% to 57% in adults and from 25 to 15% in pediatrics. We can go back to our original model of care in CF. We started off with a good base. The original clinical practice guidelines, known as the white binder, were completed in 1997. These have been updated throughout the years through guideline development and consensus statements, which have been published in the interim. These guidelines worked, and outcomes have improved tremendously since 1997. However, now is the time to reimagine CF care to address the changing needs of the CF population. The Care Model Committee was established in 2023 to develop interim guidance. We had a strong response across the US, with 158 applications from interdisciplinary team members interested in serving on the committee, and 35 adults with CF and family members of people with CF who expressed interest in serving on the committee. The red flags mark who was on the committee, and so you can see we had a wide geographical distribution across the country. And this geographically diverse representation of all care team members, including adults with CF and parents of children with CF, met in August of 2023 for our kickoff meeting. After that, we met nearly every week until we were able to put the interim guidance together. So this group did a lot of work. Our goal was to develop interim guidance for adapting CF care in the US to best meet the changing needs of the CF community, but while also maintaining excellent clinical outcomes. We reviewed data both within and outside of CF care to learn from other medical conditions. And when data was not available to strongly support a change, we analyzed what practices work and included those in the guidance, and we developed expert consensus with input from interdisciplinary team members and the community. This is also a good time for me to mention that this is not guidelines development. Guidelines come from data that's available and evidence that's available that is then often goes through a graded process, and then guidelines are developed. This is interval guidance. And so when you read the papers, I know a lot of people were wanting to see the table that had the grading of the evidence. You're not going to find that here because there just wasn't the data to support guidelines at this point in time. So the response to this process was unprecedented and feedback substantial. The volume of applications to the committee, the number of responses to the survey, and the number of comments we received back from the public comment period was larger than anything that's ever been experienced when requested by the CF community. As you can see, we had many different levels where we involved the community as well as interdisciplinary team members to receive feedback. And so thank you all for participating in this process. Many of you probably more than once or even twice, and these are long papers, so we appreciate that. And then most recently, these have been reviewed by peers as part of the publication process, and hopefully you got the email that they have been published on the website now. So I want to go through a little bit of what we learned from the Adapting CF Care survey. As you know, this was out around the time of the NACFC last year, and we had almost 1,300 responses with about 590 care team members and 680 patients and families who responded to the survey. We asked people what the most important factors were when considering in-person appointments. And this was asked of both the community members who responded to the survey, as well as to interdisciplinary team members who responded. As you can see, some of the factors fall into logistics. For example, obtaining lung function or respiratory cultures that are easier to get in person in clinic than out in the community. Some of them were more about an evaluation of an individual's health status, so the number of illnesses and exacerbations in the past year, or nutritional status, for example. And then lastly, we had some responses that involved monitoring aspects of CF care, like after changing a treatment plan, whether that's escalation or, as many of you have experienced, de-escalation of care or treatments, or a checkup of the other CF-related issues. We also asked community members how valuable routine in-person visits are to their health. And as you can see, the majority of people feel that in-person visits are still extremely valuable or moderately valuable. That felt good as a team member. I was a little worried about that question. We also asked people how often would they want to see the CF team in person. And still, the majority of people would like to be seen every 3 months or every 4 to 6 months. So the committee focused on 2 topics regarding routine outpatient care delivery. The model of care, and the traditional model of care is on the left side of your screen, and the team structure on the right side of your screen. As a committee, we asked the question, does this model need to change? And if so, what parts of the model need to change? In this symposium, you will hear presentations about this interval guidance, focusing on these different areas, including the CF team structure, the new CF model of care, and then lastly, Patrick Flume is going to present where we go from here. Along the way, we will also hear from adults with CF and a parent of children with CF to describe the why behind the interval guidance. We thought we would take the opportunity to explain some things that this interval guidance does and some things that it does not do. So this does provide a framework for more individualized, specialized, routine outpatient care for people with CF across the US. This is going to outline a team structure and model of care that programs can work towards. And notice I said can work towards. We don't expect it to happen like that, so don't worry. Tomorrow you won't get disaccredited if you haven't implemented this. We also hope that the position papers can be utilized at your center to advocate for resources that may be difficult to receive if you don't have this written down on paper. This does apply to all programs. We were very intentional as we were thinking through guidance to think about programs of all sizes and all patient populations so that the quality of care is modulator therapy agnostic and geographically agnostic, and people across the country receive excellent standard of care. And this does encourage innovation and collaboration. We want teams to share their learnings through the Care Center Network, and support is provided through some of the structures that are already in place. For example, the CFLN to help support quality improvement work for the new guidance. This collaboration and sharing of successes allows the opportunity to determine what guidance is working and what aspects do need to be modified, since every need of the changing CF population cannot be anticipated, and we recognize that. It also allows us to gather more data as a community, which may help shape the future of CF care even further. So what does this not do? The top one is what I hear the most concerns about. And so I want to make sure that you guys know this does not affect accreditation criteria. Accreditation is determined by the CF Foundation Center Directors Committee. And after our meeting in December, we're going to put together a working group to review the current accreditation criteria as well as the new guidance and figure out what needs to be changed and what doesn't need to be changed. You will see some draft revisions that'll go out to the leadership dyad at each center in the summer of 2025, and we expect that the changes will be announced next year at the NACFC, or around that time. It does not affect your funding. Your CF Center grant funding is not going to be affected by that. As you already know, there have been some accommodations to the CF Center grant, reflecting the fact that we know people are not coming to the clinics as often as in the past. This does not address treatments. The CF Foundation clinical guidelines still apply to provide focused recommendations on treatments and therapies, so this will not tell you if you should stop hypertonic saline, for example. And this does not require immediate implementation. As you know, this is not going to be a fast process. CF programs are going to implement changes over time. What projects different programs focus on initially is going to vary across the country based upon their own population, the institutional resources, and local policies and workforce. So I just want to say thank you. We are not going to have questions after each presentation today because we're going to have a Q&A panel at the end to address all questions at once. And as part of that panel, we will include some adults with CF and a parent of children with CF to join us. I also want to call your attention to the email address at the bottom of the slide, caremodel@cff.org. You can email questions, thoughts about the interval guidance, share successes, express concerns to this email address. And we felt that having a common email address for all these questions would be helpful as we move forward. So I'm going to invite Rebecca Pressler to come over here and share her why. She is a parent of 2 teenagers with CF and a member of the CF Model Committee.
Hello, everyone. Am I speaking loud enough? Great. My name is Rebecca Pressler. I'm very proud to be part of this committee. I'm the mother of a 16-year-old son and a 15-year-old daughter with cystic fibrosis. Both of my children have been on Trikafta or other modulator for many years. And like so many others with CF, they've been thriving with the addition of a modulator in their routine. So much so, I began to question how many treatments, medications, and doctor visits they even need anymore. With how complex CF can be, individualized care goes beyond medications and therapies. Other factors are lifestyle, individual preferences, and priorities. For example, my kids have always preferred not to miss school, and so we've always prioritized scheduling their clinic visits over school breaks. Since they've been extremely healthy these last few years while on modulators, we've decreased our clinic visits from quarterly to 2 to 3 times per year. And I've really appreciated our CF care team working with my family on our schedule flexibility. But even with less in-person visits, the team has always been available to discuss our care and answer our questions. As an example, last year my son's DEXA scan showed low bone density, and he was prescribed calcium supplements. This was very new to us, and so I had a lot of questions. His CF physician and dietitian helped my son and I understand the test results, and they helped me research a supplement that I was comfortable with him taking for the long term. I believe these sorts of shared decisions can truly only be made once trust is developed between the patient or family and the care team. After several years together, I trust our care team completely, and I know that they would do everything that they can for my children. And with a new diagnosis or during any time of transition, regular in-person visits are going to remain crucial to establishing a patient-provider relationship. However, over time, it is certainly possible to incorporate a mixture of telehealth and virtual communication methods to maintain that optimal healthcare without the time burden of so many in-person clinic visits. I am incredibly grateful for the positive relationship that we've built with our care team over the years. A few months ago, my son caught a virus and developed pneumonia. He had a heavy cough, and his weight and his lung function dropped significantly. Shortly after, my daughter caught back-to-back viruses and then developed an infection. Her lung function got to be the lowest it had ever been. We got really worried because it was extremely unusual for her. It reminded us that while modulators have improved their overall health, we were still at risk and we could still get sick. Thankfully, our care team treated my children immediately, and the care that they provided made us feel supported during an extremely stressful time. So while I'm grateful that my children are generally in good health, there are going to be times like this throughout their lives that require more frequent care. And so I believe it is extremely important to maintain a relationship with your CF care team. The overarching goal of CF care is to help patients with cystic fibrosis live long and fulfilling lives. My hope is that as the CF care model evolves, care teams will remember that connecting on a personal level and developing trust, along with flexibility and providing that individualized care, remains so important to the overall physical and mental health of CF patients and their families. Thank you.
Well done.
So next, we have Charlotte Close, a genetic counselor from Columbia University Irving Medical Center, who's going to talk about the guidance on the CF team structure.
So hi, as Rebecca said, my name is Charlotte. I'm a pediatric genetic counselor at Columbia University in Northern Manhattan. I'm so excited to be here and talk to you about this. This has been a labor of love for everyone on the Care Model Committee, so I really want to express gratitude to all of them and to all of you who provided feedback throughout this process. Particularly want to shout out some of my co-authors, Molly Males and Luis Gonzalez, for all their effort in this project as well. So to dive right in, I also don't have any disclosures besides serving on a CF team. So to get into it, we need to sort of set the stage for where we're going and take a moment to understand where we currently are and how we got here. So the bullseye on the right side of the screen has been used to visualize the current level of interactions between the various CF care team members and each person with CF. The innermost ring, those required team members, were defined in those 1997 guidelines, or the white binder that Dr. Brown had mentioned earlier. And then various disciplines have been recognized and added to different positions in this ring over time. I particularly want to emphasize the more recent recognition of pharmacists and mental health coordinators over the past decade and their addition to the team. So we on the committee kept coming back to this image during our discussions and ultimately did not feel like it adequately represented the dynamic nature of a CF care team. So we sought to sort of revisualize it and re-envision it to more appropriately serve the current needs of people with CF. So in order to achieve this goal, we began with a review of literature about CF and other chronic diseases, but particularly with CF, we were focusing on needs. And the majority of our early meetings were spent discussing what was a current need, what was a past need, and how needs were projected to change over time. Once these needs were isolated, we began then identifying various disciplines who were most appropriately equipped to address those needs. And then finally, we turned back to the literature to look at CF and other chronic diseases to explore the dynamics of team-based care and how that care was effectively delivered to patients. This then served for the platform on which we developed the model that we'll be presenting to you today. So to elaborate a little bit more on those identified needs of people with CF, we can break out some of the more common CF-related health complications and correlate those to different specialty providers you will see positioned on the care team structure. For example, you'll find ENTs positioned on the model who can address sinus disease. You can find gastroenterologists who can address GERD, et cetera, et cetera. So as we go through and address those positions I mentioned, we need to go through some definitions first. So those positions are essentially different groups of people, and those people have different titles. So we'll start off with the core team, and we broke out these teams based on how they serve the needs of people with CF. So individuals on the core team address needs that every single person with CF has. They can be thought of as sort of the minimum necessary personnel required to serve a person with CF. Of note, the members of this group don't need to see every single person with CF at every single clinic visit, but they must be accessible if that patient or family needs them. So, for example, every person with CF is at risk of lung infection and inflammation, so they require the expertise of a respiratory care provider, and it's the core team's responsibility to provide access to that care. And next, the group titled Essential Partners address issues that some, but not all people with CF. They are frequent, but not every person with CF does experience them. So for example, CF-related diabetes is a common manifestation of CF, but not all people experience it. So the CF core team must coordinate with a CF-experienced endocrinologist to provide access to their patients who have CFRD. Next, the group titled Trained and Trusted specialists address issues that affect people with CF more frequently or differently than that of the general population. They will share some, but not most, of their patient load with the CF core team, so they should be trained about each of those respective patients and the relevance of CF in that patient's care. So for example, some people with CF develop arthritis, and likely more will as these longer lives are being lived. So the CF core team will need to place referrals to rheumatologists who can work with the core team to address cases of CF-related arthropathy. Now, to keep those in mind, that was a lot of talking and gesticulating, I know. We can look at an image that we created with particular help from Rebecca over here to help visualize the interplay of these different teams that I mentioned. So at the center of the image, you can find people with CF and their caregivers. They are both key contributors to CF care and the hub around which the team will be consistently moving and interacting. Members of the core team will then directly encircle the person with CF because they have sort of the most primary level of interaction and provide the baseline standard of care. Then you can find the essential partners in the green who collaborate closely with the core team, and and the trained and trusted specialists who serve as a referral source for the core team. Finally, at the bottom of the image, supporting the core team and acting sort of as a foundation, you can find the programmatic components, which I will define and go through a little later in the presentation. So now I'll go in a little bit more depth about each of the roles and responsibilities listed here. So I want you to keep this figure in mind as we continue working through the presentation. So to start, I want to underscore what hasn't changed. All the core team members listed here were on that initial list developed in the 1997 required team. Much of these individuals' responsibilities are continuous over time. However, parts of their roles are evolving. So for example, of sort of role evolution, we can look at dietitians. They have historically dealt with undernutrition in most of their patients, but with the advent of CFTR modulators, we're seeing changes in body mass composition towards the other directions. So dietitians are having to thread the needle while addressing undernutrition in some of their patients and weight management in others. And furthermore, a lot of age-related health issues can be mitigated by dietary planning. So dietitians are having to think sort of towards the long term when they are providing some of their recommendations. So another example of role evolution is that of the respiratory care provider. So historically, this role was filled by a respiratory therapist, but is now filled by both RTs and physical therapists across the country. I do want to acknowledge that physical therapists have expertise that extends beyond that of just respiratory care, so they are also listed on our list of essential partners. But to get into it, we are particularly seeing changes or evolution when it comes to monitoring and methodologies, or service delivery and methodology. There's been an increased uptake in remote monitoring following the COVID-19 pandemic, as illustrated by at-home spirometry, and exercise is being increasingly used to maintain respiratory health. So now to draw attention to some changes in our more recent history, I'd like to address the mental health coordinator and pharmacist roles that had been recommended over the past decade, and we are now formally listing as members of the core team. So the role of the mental health coordinator has become invaluable to many of our core teams. Their work is distinct from that of the social worker, but pairs very well with it. As evidenced by the registry data listed on the left side of the screen, mental health issues amongst people with CF are prevalent, and obviously that require attention. So the expertise of the mental health coordinators can be used to address issues through screening, education, coordination of care, as well as providing mental health interventions when appropriate. So I know I mentioned the social worker, and this role can be filled by a team social worker or that of an independent individual, and this really depends on a particular team's patient load and their resources available. So this goes back to some of the agility we have been discussing throughout. So next, move on, we'll talk about the role of the pharmacist. So as you can see with the image on the screen, the role of the pharmacist has become increasingly useful for both care teams and people with CF alike. There's an increasing number of people over the past years that have been meeting with pharmacists as part of their regular clinic visits. So pharmacists have many unique skills, but particularly when it comes to CF, they can help navigate the population's heterogeneous medication usage at an individualized level. There are many polypharmacy issues that they can help navigate to increase access and utilization of unique treatment plans. They also have the expertise to coordinate care amongst the various members of a person's care team and can help manage medications when appropriate. So now to move on to the newest recommendation, and one that is near and dear to my heart, is the genetic counselor. So since the 1997 practice guidelines, genetic counseling has been recommended for both individuals with CF and their families at both the time of diagnosis and periodically throughout their lives thereafter. I want to emphasize that this is genetic counseling provided by an appropriately trained and certified genetic counselor or genetics professional. So genetic counselors have a wide range of skills, but particularly now it's becoming useful with the rise of universal newborn and carrier screening. Both of those screening programs have done wonderful things for both early accurate diagnoses as well as understanding the prenatal risks of CF. They've also led to more identified cases of CRMS, CF SPID, CFRDs, and CF carriers, all of which are people who require genetic counseling and are coming to CF care centers seeking that out. So, for example, recently published guidelines about newborn screening follow-up and CRMS management all recommend the provision of genetic counseling by a genetic counselor. So, also mentioned in the 1977 practice guidelines, genetic counseling should be offered periodically across a lifespan. So, some opportune times for this can be during adolescence, when kids start asking more questions about their diagnosis, when they are transitioning to adult care and taking on more responsibility, and during family planning. So as you can see in the graph on the screen, there has been an increased number of pregnancies, as well as a general increased interest in family planning amongst the CF population. So genetic counselors' expertise can be utilized there as well. And I can go on and on, but I also want to point out that genetic counselors' unique skills can be utilized to help educate people with CF and their families about genetic-based therapies, and they can help direct people towards treatments that they may be eligible for. So now we've gone through an overview of the core team roles, we can dive into the review of the other care team groups. So starting with the essential partners, I want to remind you of their definition with respect to people with CF's healthcare needs. So these team members work closely with the CF team to address CF-related health issues that are frequently experienced by people in the CF population, but not all people deal with. So these specialists can sometimes even be staffed on the core team if a center's resources allow, and we see that frequently in some of our larger centers. And I want to draw your sort of memory back to when we discussed the sort of recommendations in the core team. We did not isolate a required specialist that the center director or the medical provider on that list must be. So we have listed both gastroenterologists and pulmonologists here because both of those roles oftentimes fill the roles defined in the core center, and we want to make sure that if one provider is present, the other is as well through the essential partners and vice versa. So I'd also like to point out the primary care providers listed at the bottom of this screen. This is a long list and hard to read, so I encourage you to take a look at it either in the paper or after the presentation. But primary care providers are being increasingly recognized as useful to people with CF. Historically, many people with CF utilize the CF core team as providers of their primary care, but with an aging and growing CF population, we want to take the time to loop in primary care providers and recognize their sort of utility in the care of people with CF. Sorry, my voice is going a little bit. So, here we go. So people with CF have health-related issues that extend beyond those of CF-related needs. Oh, thank you. Cup of water. As illustrated by the list we provided here, including immunizations, general screenings like meeting developmental milestones, and or cancer screenings. And this does not need to be put onto the responsibility of the CF care team when primary care providers are available. Furthermore, people with CF should receive the same health care that people in the general population are also receiving. And we need to recognize the bandwidth and training of people on the CF core team that might not extend to include both CF care as well as primary care. Furthermore, many people with CF do not live in a close proximity to their care center. So placing the expectation of providing routine preventative care on a core team and a CF patient who does not live close to or in an easy travel distance to their care center is unrealistic. Move on to the trained and trusted providers. These individuals address issues that people with CF experience, not commonly, but more so and differently than that of the general population. So as you can see, these healthcare providers can address issues that might place them with an expertise in an area that doesn't touch CF often. So when those referral issues come up, the CF team may be reaching out to someone who has not seen a CF patient before. And the CF team then has the responsibility to train that provider about the particular patient they are referring to them and why CF is important in the care that that specialist is giving. So there should be clear communication between this specialist and the care team. And if there is not a provider within a reasonable distance of the care center, or there is only one provider who may not have the expertise in CF that the care center desires, the care center can engage with that specialist to train them about CF or point them in the right direction of educational materials about CF. Well, lastly, I want to dive into talking about the programmatic components. So these individuals and entities are thought of as the sort of foundation of the CF team. And I say individuals because we have the registry coordinators listed here, as well as labs and programs like the newborn screening lab or the sweat test lab. And their operational functions serve to support the day-to-day functioning of the care team, and without them, the regular care would waver. So now that we've gone through the structure of the care team, I'd like to play a video that one of our care team members recorded earlier. Linda Bowman is an adult with CF, and she is actually currently hospitalized, and she would like to sort of use that to hammer home the sort of purpose of her video a little bit more. She is currently struggling to coordinate care while she herself is hospitalized, and the purpose of her video is to discuss the importance of why coordination of care between various team members is important.
Hi everyone, I'm Linda Bowman, an adult living with CF. We can all agree that CF is a very complex disease. And I find as I get older, the need for outside specialists continues to increase. I am blessed with a wonderful and dedicated care team, and I'm mindful and grateful for the crucial role they play in helping me live and manage this disease. However, there are times when situations arise that are beyond the scope of the CF physician. For example, my health recently deteriorated quickly, and I was rushed to a local hospital without a CF care center. In my weakened state, I had to explain CF to doctors who were not well versed about CF, which intensified an already stressful situation. After being discharged, I found myself in need of a urologist. Unfortunately, there isn't a readily available list of specialists that is in place that understands the complexities of treating someone with CF. While still ill and compromised, I began my search for a urologist. During my first appointment, I realized that the physician didn't understand the complexities of CF, and I spent most of my visit educating them. I left that office physically and emotionally drained, knowing I had to continue to search for a specialist that is willing to take on a patient with CF. Let's be real. We all know that CF is an orphan disease, leaving us with a small pool of specialists who have an understanding of CF. My CF community lives within this disjointed space, where many of the specialists we need practice in a silo, unaware of the nuances of CF. It's a fact that we know all too well. Daily, sometimes moment by moment, we step up to the task of finding care on our own when it is outside the traditional CF protocol. Managing this disease is challenging enough, and taking on additional research only intensifies the burden. Having a referral network established between CF teams and other specialty providers would ensure that our health is addressed holistically. This not only enhances the quality of care, but significantly improves the patient experience, leading to better health outcomes and a higher quality of life.
Okay, so before I let you go, I do want to give some attention to the implementation we have been discussing about restructuring the CF care team. And to start with everyone's favorite topic, FTE, or how many care or team members does a care center actually need? So the existing guidance includes 1 FTE for every 100 to 200 people with CF that a center serves. And at this point in time, we do not have any evidence suggesting that that ratio should change. And without evidence, we rely on precedents. So given that, we do want to make some acknowledgements given the changing landscape of all of our practices, particularly with regard to some of the topics I've listed on the screen. One is program size projections. The pediatric program size is projected to remain relatively stable given that the number of newborn screens coming in will match that of those transitioning to adult care. However, the size of adult programs is projected to increase given that people are living longer and healthier lives. So we will likely see an increased need for and effort by adult care team members. So special attention should be given to both training and retaining those team members. Furthermore, we keep coming back to agility, but care team members, they have the flexibility to fulfill multiple roles. So I know we brought in some new roles, and some of them might be not thought of as something your center already has, but you already have very dedicated team members who are smart and very capable. So if they have the time, that's key, they can start to fill in and take the responsibility of some of the newer roles here. And as Rebecca was saying, it doesn't need to happen overnight. Furthermore, as I mentioned, bandwidth and overburdening, we want to acknowledge that all care team members' clinical work is not limited to the time they are face-to-face with patients. So many of us have administrative roles, leadership roles, and program support roles that aren't accounted by simply a number of patients. So to further illustrate this, we created this image right here, which is by no means comprehensive, but I think does a pretty good job in just showing the sheer number of tasks care team members take on to keep their care center functioning. It's a good one, I like that figure. So to dive a little bit further into the how of these recommendations will be implemented, we propose some strategies that we can consider when integrating new team members on a care team. This could be used for pharmacists, PCPs, or genetic counselors. Because I'm most familiar with genetic counselors, I'll use them as an example. So firstly, the genetic counselor could be embedded full-time in the core team. This position would be hired by the CF team and they would be doing CF all the time. I have colleagues who work like this and they oftentimes take on roles beyond just that of genetic counseling. They work on QI projects, they work on research, etc. Next, you could engage with a genetic counselor at your institution or hospital. This is like my role. I am a general pediatric genetic counselor, but I have FTE and time dedicated to CF care. So I see CF patients during some of my week. I attend CF team meetings. I am in close communication with the CF team. And I can see the patients during their clinic visits or asynchronously at other times within my week. Lastly, but not limited, there are definitely other strategies out there, but we had a word count to meet. You could engage with a consultant at an outside institution or a genetic counselor at an outside institution. So an example of this is a project that we are currently working on in New York State, where we are partnering with every single care center within the state and the Department of Health to provide genetic counseling to anyone who has a positive newborn screen. Some of the care centers within our state do not have a local genetic counselor trained in or experienced in CF, so those centers are working with centers who do, and we are providing telemedicine genetic counseling to babies that those, or families of babies that those centers are now seeing. So there are ways that we can address these changes and recommendations creatively and ways that increase access to care to our patients. So thank you for listening. I know it was a lot of information, but in summary, the core team structure has been of great importance and it has been very successful. But there have been growing complexities and changes in CF care, so important additions to the CF care team is that of the mental health coordinator, the pharmacist, and the genetic counselor. There's an increased need for us to partner with primary care providers to ensure that medical issues related to general health are addressed appropriately for people with CF. And this is not something I need to remind you of, but each center is unique, so they need to address the agility of their particular team members' roles and tasks to adapt in order to fill the roles here. Thank you for listening. I'm going to introduce another one of our care model committee members, Jennifer Kyle. She is an adult living with CF, and she will be speaking to the why behind the patient role is important in CF care.
Hello everyone, my name is Jennifer Kyle. I am 59 with CF and I am not on modulators due to side effects. Since moving to Kentucky, I now live 2 hours away from my CF clinic in Louisville. Because of this, I've had to learn all about remote monitoring and how to make it work best for me. I get all my blood work, sputum, radiology tests, and port care done at my local hospital. However, my CF clinic does not have privileges at my local hospital. So when orders are sent from my clinic, I have to have an in-house physician who can sign off on those orders. I was able to find a primary care physician who can help with this. Now that I understand how this system works, things flow much easier and faster. However, this type of disjointed care leaves me with the responsibility to coordinate my care with my PCP and my CF team. Keeping an eye on my patient portal for test results and uploading them directly to my CF clinic also helps with a fast turnaround. I dream of the day where I can share access to my medical data via a single patient portal from which I can message both my CF clinic, PCP, and other CF-related physicians simultaneously. I also look forward to my CF clinic and PCP communicating directly for my care. Telehealth and home spirometry also help to reduce travel and increase my care. In fact, we just used telehealth to determine it was time to start IV antibiotics, and my clinic and local hospital were able to set up port access so I could start my meds. This is just another example of how telehealth is incorporated into my care. I am grateful that my local hospital and CF clinic are willing to adapt to this type of CF care to make living with CF just a little easier. These are just a few examples of how the future of CF care is changing and how people with CF can adapt their care according to their needs. Thank you so much.
So now I'm going to invite Dr. Danielle Getz, Pediatric CF Center Director and Pediatric Pulmonologist at the University of Buffalo School of Medicine, to talk about the care model.
Hi, everyone. I'm so happy to be here today to represent the committee for the care model. It's been a real joy to work with everyone over the past year. So I wanted to talk about the care model. I have no direct financial relationships to disclose today, and I'm also care center director, so I may have influence for that. So we wanted to talk about visit frequency. I think all of us know that that's something that comes up a lot with people with CF. And we, as you've heard here from Dr. Brown and Charlotte, we've had a wide range of opinions on should the visit frequency remain the same, should it be decreased. We had a wide range of opinions, and I'm glad everyone was able to express them. So I thought it was interesting, as Dr. Brown presented, that about 90% of people with CF still want to be seen between 3 and 6 months between their visits. So we took a chance here to kind of talk about these thoughts, and we wanted to really emphasize holistic health as like a way to concentrate on what the visit frequency should be. And we understood, again, we were not rewriting the guidelines on therapeutics. We didn't change any of the care guidelines that are already in place. And our overall goal as a team was to try to reduce the burden of care if possible, but not compromise health with undue risk with the visit frequency. So as Dr. Brown had mentioned, we wanted to be modulator agnostic. So all patients, regardless of modulator status, we can think about their visit frequency kind of equally. So the reasons behind this were, we took precedent from Burkholderia cepacia patients, for one. Remember when we tried to separate out those clinics, and it was hard to determine, okay, who has the germ, who doesn't? Are we missing other people, such as those with NTM? So we thought it better at that time to implement precautions that would affect everyone and keep everyone safe. Also, as you saw from some of the modulator data, there's 10% of people who are not eligible for modulators, 10% are not able to take for other reasons due to complications, and then about 25% are estimated to have a reduction in their dosing or modified dosing. So we can't really be totally sure, how these people will be effective. There's also a group of people in the registry who are not prescribed modulators, although they are eligible. And this group, although they do have a slight reduction in their lung function over time of about 2% over the last 4 to 5 years, they may not need the same visit frequency, even though they are not on a modulator. So for all those reasons, we decided to kind of make the decision on visit frequency independent of their, quote, modulator status. So the next thing, as Dr. Brown also mentioned, we wanted this guidance to be applicable to all regions of the U.S. And all programs, no matter their size or location. Again, we wanted to emphasize holistic health, so not only their lung health and their GI health, but their mental and social factors that are involved, and I'll talk about those. We know there's some age-based recommendations that we should have based on there may be risk in younger people or also older people with advanced lung disease, so we wanted to take those into account. And then, as Jennifer Kyle mentioned, there's an impact of telemedicine, and really remote monitoring can be used in different populations, so this might be able to reduce the burden in some people. And importantly, I'm so glad that we had people with CF and parents on our team, because we really need to address what are their needs and goals, because we know everyone thinks differently and they have different needs. And as someone else had said, if no data existed, we did tend to lean on precedent, because we know that the CF care model, even without modulators, had resulted in multiple improvements in quality of life in CF patients over time. So the components of the care visits are, they've always been kind of important, and some things have been added on over time. Charlotte talked about the interdisciplinary assessments, and these are usually yearly for most members of the team, although adding the genetic counselors and pharmacists, these will be discussed in that paper on the care team. But we did want to make sure we address pulmonary function testing, as always, respiratory cultures, lab work, including OGTTs, imaging, and then certain screenings that we always do, including mental health screenings. We wanted to talk a little bit about social determinants of health, as that's a more upcoming issue, especially with the new CMS guidelines in 2025 that will require that in screening for chronic diseases. And then cancer screenings. As you may have heard at this meeting, there are a lot more cancers that can be evident in CF patients, especially as they age. We also mentioned immunizations and exercise assessments as part of routine CF care. So when we looked at it, again, we were trying to sort of let out the reins on people who could be seen less frequently because again, a lot of people, they'll ask me, oh, Dr. Getz, can we come to clinic in 4 months? And is that possible? So we want to do it without having a lot of extra risk, but if possible, letting out the reins. But the committee felt strongly that there are certain populations that we really shouldn't reduce the visits significantly to less than every 3 months. And these are people with something new. So like a new diagnosis of CF, obviously, and then also like a new diagnosis of something else like CF-related diabetes or another significant complication. And for those patients, we really want to build relationships with them. It takes time for them to feel comfortable and we talked about self-efficacy and building their confidence and taking care of their care concerns. And also the advanced lung disease might fall into this group because although their lung disease may be stable, they may want to be monitored more often to make sure they're not having complications. And then infants and toddlers, they have a lot of routines that have to come into play, developing those routines. Their growth and development is changing so often that there was really no evidence to reduce their visit frequency further at this time. For preschoolers, we know this is the age when a lot of therapies like modulators themselves are being introduced, so we really have to look at the treatment responses, and we didn't feel at this point that we should recommend routinely reducing the visit frequency in this group. This is also a developmental window where things are changing so rapidly that we felt that the every 3-month visits would be most efficacious. And then some other groups that we felt as a committee that would benefit from every 3-month visits to continue would be those undergoing transition periods. So there are so many transition periods in one's life, not only in their health, but in moving to a new center, having a significant change in their health, or a new job, new occupation, risks. So we really wanted to see the effects of that transition on their health parameters and see them on average every 3 months. Also, the transition periods are times to strengthen relationships with those people and help them as they go through these changes. Pregnancy, now that the Mayflower study, more and more pregnancies occurring, that was another thing we talked about, as well as adolescence, because we know people taking more risk-taking behavior as well. And then health-related social needs, I'll talk about a little bit, but we felt that for some patient populations, they really need that check-in that may need to be in person because telemedicine might be a barrier rather than something that's really advantageous for some groups. And then I think I mentioned, but anybody with a change in health status, they really need a chance to see their treatment response, as we're changing things more rapidly. So in summary, the frequency of visits for this position paper, we did not really change in terms of infants, toddlers, and preschoolers. And then for children greater than or equal to 6 years and adults, spacing visits out to every 4 to 6 months can be considered when health is determined to be stable in all domains and the patients and families are comfortable with this. And the data that we mostly used for this was from the paper published in 2023 that was reflective of registry data pre-pandemic and before modulators from 2006 to 2014, where we saw that people who had gaps in care, which is shown by the dotted lines, of greater than 12 months from their CF center, had significantly lower lung function than the solid lines were people who had regular care at their CF center. So they, in panel B, they show age 15 to 25 are the particularly more risk areas. So that's why for adolescents and young adults, consideration to more frequent visits should be given as well. And there was, for the heterozygotes seen in panel D, there was more decrease in lung function. And the longer the gap, the greater the decrease in lung function as well. So that's why, as a committee, we didn't feel comfortable spacing out the visits to more than every 6 months. So we've been talking about telemedicine a lot because we really hope this is a way, even though 20% of patients are using it for their their visits right now, it is a way that might help reduce gaps in care. And we all know there's multiple benefits and barriers that have been published. So the benefits we know, improved access to care, maybe there can be more frequent contact because people aren't missing school and work. They have reduced travel costs. Improving patient engagement are possibilities. But then the barriers, we all know the disparities in being able to connect to internet, the federal and institutional barriers to actually having a license to deliver care in a different state, et cetera, et cetera. Technical difficulties we've all experienced, I'm sure. So we really are working, though, to try to have some things like remote monitoring that can help, influence these visits and make them more useful if there are going to be more frequency between visits. So spirometry is so important, and we felt that in children 3 to 5 years, spirometry should be attempted at clinic visits, and so there's really no change in the guidance. For children greater than or equal to 6 years and adults, spirometry should still be done in clinic at least 2 times a year, and that would be during their clinic visit even if their visit frequency is reduced. And then in between, they can definitely try at-home spirometry or at a local facility doing spirometry, but this would be like an adjunctive. And we realize there are challenges such as entering the data into the EMR and then children performing spirometry at home reliably. And we also do know, based on studies that are published more recently, that coaching should continue for people who perform spirometry at home. So it may be useful, though, for exacerbation triage and follow-up of people who are seen in clinic as well. And there's a session on remote monitoring tomorrow that will help elucidate some of the studies that are ongoing regarding spirometry done at home. So as a committee, we really looked at the fact that chest CT seems more useful than chest X-ray for surveillance. So we really wanted to emphasize that using chest CT as a way to monitor is proposed. And there's already evidence for this in the infant and preschool guidelines of using chest CT. And there's also obviously a lot of data being collected. And at this point, I think we don't have, still a research question, the cadence or how frequently should chest CTs be performed. So, but it's something to strongly consider for monitoring. And it still remains a research question in terms of the number or frequency they should be done. And then, of course, MRI and other techniques are being researched as well. So in terms of respiratory cultures, Dr. Brown also showed this figure, but I just wanted to reiterate that sputum cultures definitely dipped with the pandemic, and then we did come up to about 2.8 per year. But as a committee, we really felt strongly that it was important to try to maintain as many sputum or oral pharyngeal cultures as we could per year, and to aim for 4 per year. And that was because it's still so important to eradicate Pseudomonas when we see it, and to prevent lung function decline and bronchiectasis, because we know that modulators can decrease the frequency of having difficult organisms, but they don't reduce them completely. So we definitely wanted to make sure that we can maintain cultures. And as Dr. Brown had also mentioned, there's really in children, 87% of specimens are obtained through nasal pharyngeal swabs, and then in adults, 46% are obtained. So it's pretty high numbers. So how are we going to get the cultures that we need? We need to continue to do sputum or oropharyngeal cultures at every visit. And many people are submitting their specimens to a local facility if it's possible, or mailing in their specimens to the CF Center from their home. And then people are doing studies, and that's also in the remote monitoring session, they're talking about obtaining oral pharyngeal swabs at home as well and sending them in. So we are doing research on this. And induced sputum may be used if clinically indicated. And the frequency of imaging, such as for non-tuberculous mycobacterium, might need to be increased if we aren't able to get the cultures that we need. So the frequency of labs and other evaluations didn't change significantly, but we did address doing screening in children for familial dyslipidemia at least once. And this is also something that's going to be collected in the registry upcoming, so we put that in there. Blood pressure should be monitored generally annually, which is usually done. And then the interesting things were about fat-soluble vitamins, because we know with starting modulators, you want to check levels and adjust doses as necessary. And also, especially for fecal elastase, there's data that fecal elastase levels can improve after starting modulators. And the nutrition position paper had also agreed that they should be rechecked after starting modulators, especially in childhood. We don't have an optimal frequency and timing for that as yet, so this is an area of ongoing research. There is a nutrition session tomorrow as well in the afternoon that will discuss both of these monitorings. And then for CFRD screening, in children greater than or equal to 10 years to adults, we still recommend annual screening with OGTT and with clinical signs and symptoms of CFRD. Although there's some data that's accumulating on continuous glucose monitoring, it could not be recommended yet, and I'm sure we'll learn more about this in the plenary, which is this evening. Other important screenings already have guidelines, including bone health and cancer screenings. And I just wanted to refer you to some upcoming sessions on those. But I think the important thing to point out is the necessary role of the CF team in discussing with the primary care physicians or endocrinologists and specialists regarding these screenings to make sure, because we do know of the increased risk in CF, so we may need to help the primary care physicians and other specialists make sure the screenings are done. Mental health screening we know is so important and has been recommended since the 2016 guidelines, and so this should still be offered annually to children greater than 12 up through adults. And we did realize that screening is so important that we would consider having it by telemedicine is better than not having it at all. But you may have to think about the question 9 and the suicidality factor, because a lot of that, some centers have difficulty screening for that because you need a immediate care plan to make sure the patient is safe. So social and determinants of health screening, which is also called health-related social needs. There is actually on the my.cff.org website, there is a toolkit, and this goes into some of the areas of screening. And a lot of the questions are asked on the social work assessment, but this may be an area that will expand in terms of like making sure we ask all the questions regarding housing and financial status that patients are going through that also affect their care. And there's actually a quality improvement project going on with several centers that was presented today as well, that was called Elicit. So this is the QR code, and please feel free to scan it for our care model paper. So the care model is already evolving before our eyes. It's been compelled by changes in health status and technology, as we've related here. And children greater than 6 years old up through adults, we have a framework to consider spacing out the clinic visits to every 4 to 6 months when appropriate. And we want to emphasize that the model can be fluid. It may go up and down where the visits need to be increased in frequency as complications arise. And telemedicine and remote monitoring can potentially bridge care between the visits. We wanted to emphasize holistic health and maintaining quality of life and longevity, and then the mutual trust that's required among the care teams and with the people with CF that was mentioned by Rebecca earlier. So thank you so much for your attention. And I'll now introduce Dr. Flume, who will say, where are we going from here?
All right, thank you all. You've heard what we've considered, what we put together, and what we came through to recommend. And so the question now is, where do we go from here? Because we have a huge opportunity. First, I have a whole lot of disclosures, but none of them are really relevant to what I'm going to talk about today. So nothing is different from what you've heard before. But I want to start by reflecting on the process. So this team was recruited and elected to start, and we had our first kickoff meeting in August of last year. So in 1 year, this group reviewed the data, completed a survey, analyzed that, put up with my nonsense, put it out for public review, made adjustments to that, and then put it back out for peer review so it could be published and is available for you now. So this was a very motivated group, I would say. They were excited to be part of the process, and when given the challenge of a very rapid timeline, anyone who knows me knows I like timelines, and sooner is better than later. And they met it. They met every week in many cases, and when they were given challenges or feedback, they responded. They certainly felt comfortable speaking their mind. At least I think they did. So it was a pleasure working with this group. So what we tried to do is to provide some guidance. This is a chance for us to look at where we are. How could we do better? We've been working with a set of recommendations that we don't really know, is this best? We just know it's what we've been doing, and we have some results to report. What we did not do is we did not take into account whether one has limited resources. We know that there are centers, there are countries that have more resources than others, but we didn't want that to be the factor. So for example, if someone says, well, we don't have a genetic counselor, that's not a reason to not have one. So we wanted to make sure that what we were trying to do was define what would be best practice. How would you want to be treated? Now, what we also did not do is this is not luxury care. Because we won't provide this for every patient out there, it doesn't mean we shouldn't. We just tried to focus on what really identified as best practice. But nonetheless, when we got feedback from the community, what we could tell was there was a lot of anxiety. There were anxieties when we started. It was really interesting to hear the community speak and say, we want to see you less often. And then another side was saying, we can't imagine not being seen at this frequency. So how do we find a way to make that work for everyone? So there were a lot of concerns about questions related to the team structure. And as you've heard, I won't go through all of this, we wanted there to be a certain amount of flexibility. And some of that might be related to the size of your population, the needs. Some of the roles that we have that people fill, there's a lot of overlap. Your program coordinator, your social worker, your mental health coordinator are often working together on similar aspects of care. And so we wanted people to have that degree of flexibility to be able to implement the appropriate team to take care of their patients. People were concerned about the financial support, and as you heard from Rebecca, this is not what that's about. The center committee will do their part to try and figure out, well, what is required that will factor into the grant or your review process. And then others were concerned about the health system support. How could we be talking about adding more people when the health system might think that it's time to provide less? And what I hope we have done successfully is demonstrate that the needs of these patients have not gone away. They have changed, but they are still many. And this is not a cure. We have not cured our patients, and they still have health problems, as you will see. But also, as you've heard, we have team members now that we didn't have before, and can you imagine not having them now? For example, your mental health coordinator. Anybody, you ready to let it go? I just don't think so. I think it's a vital part of care. So we were trying to find that balance between what is too much and what is not enough. And again, what we're talking about is surveillance. We're not talking about when people are sick or when you're following up to see if they responded appropriately. This is about routine surveillance care, looking for opportunities to intervene before harm is done. So the first question one might ask is, and it was asked by one of the reviewers, is this really much of a change? Doesn't seem like a lot. And so the previous guidance talked about how many visits, how many cultures, and how many PFTs. And you look at what we've recommended, and yeah, it's not a lot different. But what we've tried to do is to help you identify that group where you might let the reins out a little bit more. So those folks over the age of 6, where they're doing well, and they seem to be doing well consistently. So I want to thank the CF Foundation and the registry folks, and particularly Josh, for helping me pull together some numbers. I'm going to show you a lot of numbers now, and I'm going to walk you through them, so hang in with me. To see how much have things changed. And so at the top are data from 2018, which is before the triple was out for us, and then in 2022, which were the most recent data. And so when you look at the frequency of visits, you can tell that the number of visits has gone down, but not by a lot in terms of the number of visits based on those different categories that we've put. And when you match them up with what we're recommending, we're still kind of in the ballpark. Now, one caveat to that is these visits include sick visits. This includes encounters. So if a person comes in with exacerbation, it gets tallied in there as a visit. So, there are perhaps some worries that we might have. When you look at the number of PFTs that were being performed from 2018 to 2022, those numbers have decreased as well. But they're still within the range that we are saying is probably okay to be able to detect change, that you can monitor those patients. And when you look at cultures, the microbiology, the frequency of cultures has gone down. Actually, the character of those cultures has changed as well, which we might be a little bit more nervous about. Those are perhaps a little more concerning if it's important for us to get more knowledge about, more data about microbiology. We may find that we don't need that much information. That would be useful to know. But in terms of where our guidance, that's where things are. What about those patients that we are perhaps have greater concern about? And we're talking about the times of transition with the adolescents, patients who are pregnant, those who have advanced lung disease. You can see that between 2018 and 2022, those frequency of visits have also decreased below what we have recommended. The frequency of PFTs has decreased, also below what we have recommended, and the frequency of cultures have decreased and below what we have recommended. Should we be worried about that? I don't know. That is an area of which we can try to understand this. So you've heard a little bit about how to implement. I'm not going to go through a ton of this, but I do want you to have some ammunition when you talk to your health systems about the needs of these patients. Again, you're tailoring it to the needs of your center, but it's important to know that these patients are not cured. I'm showing you two images from two of patients from our center who had an excellent clinical response to the modulators, and this is what their CT looks like after they're on modulators. They still have disease. They have bronchiectasis, they have thickened airway walls, they have mucus retention. They're just not coughing up a lot of sputum. And I could show you similar images with patients who have mild disease. So the disease is not gone. The list of complications that we think about or we ask about and we look for, they have not changed. And when I have been asked about questions, or maybe we don't need CF teams anymore, the primary care doctors can manage this. Has anybody looked at how long it takes to get in to see a primary care provider? Or has anybody asked them about their willingness to tackle a patient as complex as having cystic fibrosis? And I think the answer to that is no. They are welcoming. If there's one patient population which physicians are very quick to refer to a center, it is patients with cystic fibrosis. They're starting to do that with other cases of bronchiectasis as well. But this is going to require communication and coordination, as you've heard from some of our patient representatives, talking with the families, but also talking with the primary care providers. There are patients who believe that the CF physician, the CF team, is their primary care provider. And for all I know, the CF team willingly accepts that and acknowledges it. But there are others I've heard from, they're like, no, we are not the primary care provider. And you've heard issues about distance. And can you really be the primary care provider if someone lives 4 hours away from you? So we are advocating that at least have that conversation with the patient and their family as to who is responsible for what. And so, for example, the primary care provider might be okay with looking for cancer screening, but do they know that in CF we recommend it at an earlier age? My guess is no. Same for diabetes screening. Who's responsible for vaccines? It's a simple conversation. Have it on the table, and then you know what you're taking on and what you're not, and you can have that relationship with the primary care provider. So what comes next? We've described this as interim guidance. It's a new set of guidance to which you can try to follow and implement to provide what would be best care. But is it best? I'll try my Jerry Nick imitation of, I don't know, but it's what we've recommended. And so it's just an opportunity for us to see how we can do this. So we have based these recommendations on precedent, existing data, expert opinion, input from stakeholders through surveys, through external comments, and yes, through peer review. After all of the revisions, it went back out for peer review. But are these best practices? That's what we have to find out. For some, it's probably not enough. For others, maybe it's still too much, and we would be better off if we had some data. So you've heard throughout some of the questions that might be relevant. Visit frequency, what is the right number? Could we loosen the reins in some patients, or have we failed in others? And how do we know who they are and communicate that with them? Imaging. Here you've heard us say CT is better, chest x-ray not so relevant. When's the right time to get it? What's the right cadence? How often should we get them? Are there circumstances that might prompt us to think about getting CT scan? And are there new technologies such as MRI that might make us think differently? Microbiology, not just how best to identify pathogens, but what's the right sample to use? I feel very uncomfortable using oropharyngeal swabs, and I appreciate how the pediatricians have lived this life for the whole time. But we were in a world where we had 15% of our patients had mycobacteria in their cultures. I don't know what they have now, and I can't get it with an oropharyngeal swab. is eradication. Do we still need to have the same approach, that same aggressiveness to care when we see papers that talk about we're not identifying pathogens in the cultures anymore on patients on modulators? At least in the adult population, those bugs are still there. We know that to be true. And what is the best frequency for surveillance? So we have a lot to learn on the microbiology, and then telemedicine. After the pandemic and telemedicine, you've seen many, many papers that have been published that we can do it, which is not quite the same as, is it better? How has it improved our ability to provide care for our patients? So there still is a lot to do with that. We've become very keen to this notion of asynchronous visits. One of the worries that we have talked about is if we start seeing people less often, does that mean on a single visit we're cramming too much stuff into it, and actually it's for naught because it's too much? The patients and families just say, I'm saturated, I can't remember everything. So asynchronous visits might solve some of that some of your team members could reach out and communicate with patients outside of clinic and so forth. So again, thank you to Josh and the registry team for providing these data to look for the opportunities. So here are examples of, again, 2018, looking at the proportion of patients in each of these age groups that had this number of visits. And so you can see that in 2018, the majority of patients were having visits, at least 4 or more visits per year. And then in 2022, those numbers have changed. So I'm just highlighting it so you don't have to look at all the numbers. But you can look at the proportion of patients at all of these age groups that had at least 4 visits. That number has gone down. And then you look at the adult population from 50% to 22%. Is that something we should be concerned about? Look at the number of patients, the proportion of patients who had only 1 visit in that year, and that's gone in the adult population from 14% to 29%. Is that something we should be focused on, that that's a group that may be at greater risk? That's something we'll have to follow up on. What about PFTs? Similar things, numbers have changed, and here I'm showing you the proportion of patients with good lung function, greater than 90% have predicted. The frequency of visits has decreased, and only 31% are having the PFTs, coming for PFTs, and the proportion of patients that have just 1 visit, that number has gone up in the healthier patients. Is that okay? Or are those patients now going to have some rate of decline? And if you look at those with severe disease, with lung function less than 40% are predicted, you can see that those having at least 4 visits, which is what we've recommended, that proportion has gone from 60% to 30%. It's been cut in half, and it's more than doubled in the proportion of patients who have only 1 visit. So here we've advised that is a group of concern, and yet there's a greater proportion not being seen. And you see the same things in those patients who are underweight. We've talked about the overnutrition in our patients, and that warrants some work. But in terms of those who remain undernourished, they're not being seen as often. And then those that we worry about because they have frequent exacerbations, that the proportion of those who are seen often, keeping in mind some of those numbers, those visits were exacerbations, that number's gone down, and those having just 1 visit a year has gone up. So how do we do it? Well, we have a number of ways of trying to evaluate this. We can look at real-world data, like the registry. We can do quality improvement, or we could get clever and design some prospective studies. So real-world data, I'm going to take you back to a benchmarking study that was done. This was published back in 2014, where the CF Foundation went and looked at specific centers to try to find out, well, why did some centers have better results, better outcomes in the registry compared to those that had not such great results? And there were a number of features they found out, but one of them was early and aggressive management of clinical decline. So if surveillance is about identifying opportunity to intervene, you cannot intervene if you don't know that there's a problem. Registry data. Here you saw an example of where we identified patients that had larger gaps in visits had a greater decline in lung function. Now, there's a lot that could be unpacked with that, but again, trying to identify opportunity to look at those. Now, I confess that using registry data can be challenging. There are limitations to the registry, and maybe they're really not much more than hypothesis generating, that we could, identify things that might help us. But one challenge I put to the community is, are there data that do not currently exist in the registry which would help us to answer this question? And so if there are thoughts, send them in and we can discuss them at the registry committee to see if we're going to add anything to the registry data collection, what might those fields be? Quality improvement. The CF Foundation put out an RFA for QI studies. These are principally related at remote methods of evaluation, and so you can see the number of projects that have been supported, ranging from doing home spirometry, home cultures, remote testing, additional screening. And so this is now moving forward, that there are individual teams looking at some of these quality improvement processes. And I'm showing you a number of abstracts that are being presented at this meeting, which are also trying to address some of those topics. I have the luxury of seeing these abstracts long before you all, so I can pull these titles out. And I'm not going to walk through all of them, but there's more than a handful to at least go take a look at and see what people are doing and how that might help us get to a better understanding of what is best practice. And then, of course, prospective studies. This is where it gets more difficult. How are we going to do this to try and generate data to tell us what's best practice? And if you're waiting for me to tell you what that prospective study looks like, you're going to be waiting a long time, because I'm asking you to help figure that out, that there are ways to randomize by center, not just by the individual, that we could begin to try to implement this with our patients to try to see if we can identify best practices. So I'm going to close with what we've tried to do is offer interim guidance that we think could serve as best practices for both team structure and for models of care. The changes that we've offered are incremental. We acknowledge that. It's not a huge swing, but it's a start. We're adhering to precedent when data are lacking, and so we were careful to recommend big steps when their data weren't there. But we now have an opportunity to implement these changes and help refine this model over time. And so with that, these are the two papers that you can download now. And we'll leave this on the screen for a little bit before we invite Jen to join us as part of the panel discussion. And we're ready to entertain your questions and your comments. So thank you.
Before we have Jen join, just so that y'all have time to get the QR code done, I can answer one of the questions that, or actually a couple of the questions that have come through electronically. You can submit them electronically. We may or may not be able to see them very readily, so I have my phone and the iPad, so hopefully we'll get to them all. But there's a few questions about the FTE requirements and what that will mean for CF centers. And I just want to point out that that's going to go back to what I was talking about with the accreditation criteria. So these papers, we actually initially were not going to include an FTE table because we didn't want to walk into that accreditation realm. But we heard overwhelming feedback from center directors as well as the center directors committee that that table is actually really helpful to have it published, so that when people go to their administration and lobby for resources, they have something in print that can help them get information and get resources. So as of right now, that table is just meant as a resource. As the center director committee reviews that and looks at that table, some of that may become part of the accreditation criteria, and you'll hear about that. And if you don't meet that guidance, if some something changes and you don't meet that guidance during your site visit, your site visitor will lobby your administration to help get you that support. And sometimes having it written down in a site visit letter that you really do need more social work or you need more mental health coordinator is the only way to get things done at an institution. And so don't worry about that for now. Use it. Hopefully it's helpful to you, but more on the accreditation criteria will be available next year around this time.
I will add that that other figure that was shown earlier, showing all of the duties that people do outside of the clinic, is intended to be a very powerful thing for you to show to your administration or when you're doing creation of a job description, when you're recruiting for that, so people know what all their responsibilities are.
Oh, Linda joined.
Linda's joining us as well from her hospital bed.
Linda, it's really good to see you.
All right, we welcome the questions, comments. Did we get it right? Close to right? Wild swing and a miss?
Hi, thank you so much for all of the work this committee has done on pulling together the resources and sharing the new care model suggestion. I guess I have a question. I'm a little bit shocked, to be transparent, at the lack of a PCP being suggested for the adult core team. Just knowing and recognizing some of the commentary that even was in this presentation about the stress and burden that's on the current health system, and knowing that on average, I think most of us can agree if you go to your PCP, they maybe have 15 minutes to engage and meet with you, and those times have changed, where often or not, you don't necessarily have that strong relationship that maybe 10, 20 years ago you may have had with a PCP. And knowing that our adult community faces a lot of very specific challenges that, as you all acknowledged, a average PCP may not be informed or be educated on those specificities around the comorbidities of the disease, as well as just in general, some of the things that are a little different. I was even listening to some guidance earlier around needs for colonoscopies being very different. So in light of all of that, can you share a little bit of how that insight came to be that you didn't include a PCP for the adult clinic with the aging population?
I'm happy to answer that. So there are centers we know of who do have a PCP or an internist or a family practitioner embedded into their program. And that's a model that works for them. In South Carolina, where our patients come from the entire state, it's not a practical step. Again, having that primary care provider in Charleston doesn't really satisfy the needs of a person who might be in Greenville, South Carolina, for example. So what we really wanted to do was acknowledge the value of the primary care provider and what that raises up there. But in terms of having them as a core team member, we felt that was a step too large. So that's why we put them in the essential partners.
Yeah, no, I think that makes total sense. I guess out of curiosity, so we also are in a rural area, and our clinic services a large distance. And just in consideration, I wonder if there's opportunity to do research around how often the adult community is seeing an actual PCP outside of are seeing an adult PCP in comparison to how often they see their clinic. And I think it could be potentially surprising.
Sounds like a suggestion for a potential addition to the registry data set.
And just kind of to piggyback onto that question, one person asked, and it just went away, if there's a templated letter from the CF Foundation that's going to help centers communicate with PCPs and help educate them about CF and start those communications. And so, no, there's not. There's going to be some resources, educational resources, implementation resources that come out of what we hear back as a committee and from the CF Foundation, but then also from you guys. So at your center, if you develop some cool letter that goes out and helps bridge that gap between centers and the primary care doctors that are out in the community, please share that. Share it widely so that we can all adopt it and not all be starting from scratch when we're doing this work.
Question on this side.
Cool. Thank you, guys. Excellent talk. Wanted to see if you could comment a little bit about the mailing of cultures and how to get the 4 cultures in those groups that we're going to do just 2 visits a year. Is there a way to get how do those get shipped back to you guys? What do you have to store it on, and kind of how do we get it paid for back and forth for the mailing and returning and all that?
Good questions. I had these concerns because at my center we don't have a way to do this, so it would have to be something like at an individual center level that they'd have to figure out, because at some centers it might not be possible to mail, but that's why we're talking about like different quality improvement projects people have been doing to try to find ways. Like, could they just drop it at the clinic if they live close enough? But if they live far, we may have to be creative about ways that it can be done. And if not as many people are expectorating mucus, we know that that's why there's a QI project on doing the swabs at home as well, because we are going to have to be a little bit creative to develop those ways of maintaining the cultures.
Rebecca, do you want to share your experience with trying to get remote cultures? We know that there's we know that there's work to be done, and I think Rebecca has a great illustration as one of our
Sure, it wasn't a great
members.
Experience. My daughter I wanted to get her cultured. She'd been having some issues, and I just was curious, hey, if we could get a culture real quick, can we see if something's growing rather than just, going on an antibiotic blindly. But I didn't want to have to drive into clinic. I was like, hey, we're going to be at our primary doctor. Can they just do it while we're there? So they sent in the script and or the orders, and then we went, and they walk in with a jar, and okay, she needs to cough. And I was like, no, that's not how cultures are done. So I explained that I wanted them to have, the swab, and you go in her throat and she coughs and you send it back in the vial, because that's all I've ever seen done. They leave, come back in. We don't, this is what they said you have to do. So she comes in with the swab, because she thought I meant you're going to use the swab to choke her and make her cough. So the nurse is standing there with the swab that we need, the vial to put it in, everything, and then this cup, refused to do what I said because she didn't understand. And my daughter and I literally are watching her just throw it in the trash, and we walked away very frustrated at the primary doctor, and just, I shared the feedback with our care team, hey, primary doctors don't know what they're doing. We're coming to you from now on. It's just not worth it. So it was very frustrating. My daughter felt it, and she's going to be taking care of her own care soon. And she now has the attitude of, primary doctor doesn't know how to take care of me. So lots of work to be done on that for sure.
Tomorrow, this is Mike Powers from Portland. Tomorrow during the remote monitoring, Chris Saragusa's group is going to be presenting that data. And there is a goal for the CF Learning Network to maybe convert that to an iLab, which then will have 10 to 20 pediatric and adult centers test different methodologies to do remote monitors. And we hoped, that'd be launched in 2025, and maybe by 2026 we'll have some data that we can share.
Going back to some of the issues with if we transition some of these care to PCPs, and in pediatrics, it's a little bit different challenge than in adults. But at the same time, the PCPs have that very limited time. So if they're going to talk about CF stuff, which might be great, and even if the PCP is knowledgeable and been educated about this, it means they're not going to take about other things, like, normal development of a child and all the other things that they talk about. So is there some advocacy or resources from the foundation to the PCPs actually to help manage their time resources that they're going to be investing in this? And one of the ideas is potentially identifying maybe geographically based kind of champion PCPs that have some extra education in this, who are interested in this population, but they didn't want to become, a pulmonologist, a gastroenterologist, or other kind of subspecialists into this field. And this way you can give them some resources to help. They will have the knowledge and still serve the community and the specialists at the same time. So just a suggestion.
I think can you hear me? Okay. I think all of what you mentioned were great ideas. From what I am aware, we don't have resources right now, and several of what the ideas you mentioned would make for great projects and QI projects so that data can be generated and subsequent resources afterwards. What I do want to emphasize is our continued emphasis on communication, and particularly bidirectional communication between the CF team and all specialists interacting with. So when you establish care with a new patient and a new PCP, we're really hoping that some level of communication occurs between PCP and the core team to appropriately delegate tasks so we know what is CF, what is general routine preventative care. We're not doubling up on things, and people aren't taking on responsibilities that they aren't comfortable with.
Charlotte, while you're kind of at the microphone, they are asking why a pulmonologist is now an essential partner and not a core team member.
Yes. So I don't think I accurately discussed this. I was having a bit of a coughing moment. So in the definition of our core team structure, we did not sort of isolate a specialty that the medical provider or the center leadership must have. So in order to make sure that all of our bases are covered, we included what we consider essential specialists on those lists of essential providers. So in instances where there is a gastroenterologist who is a center director, we do think that having a pulmonologist available and accessible to the patients is essential, which is why we included both of those providers on that list.
And I think a lot of people don't realize that there are models out there that already do this. There are some centers that do not have a pulmonologist on their core team. And so we actually missed that when we first put this out there for our first round of feedback. Somebody, I think it might have been Clement Wren, was like, what about the pulmonologist? And so we realized we needed to add it in because, again, not every CF center has a pulmonologist in their CF core team. So just different models of care that are out there. We wanted to make sure we flex the model to meet everybody's needs.
Thank you for a wonderful discussion. I'd like to ask our two people with CF Online a question. How do you utilize your primary care physician in your care plan?
Jen, want to share yours first?
Sure. My primary care, like I said in my video, she steps in and signs off on the orders that are sent from my clinic so that I can get the work done at my local hospital. Sometimes she also helps me to accomplish other goals. She's good at, she doesn't know much about CF, but she's great at listening when I'm trying to teach her about CF and understanding what I'm going through and having to maneuver so many different pieces of the puzzle for my care. So she's great for that, and I use her for all those reasons. She does not provide basic things like flu shots, vaccines, things like that. Those now we're almost forced to go to like your local Walgreens or CVS to get that done.
That's true.
And she just basically, she helps me play the game that I have to play in order to keep my care going. For instance, she just signed off or ordered an MRI for me because I just tore my meniscus in my knee, and I'm actually going to fly back to New Jersey to my sports med team to get it taken care of. So she was able to start the process because I needed an MRI first in order for me to get that appointment back in New Jersey. So things like that, she comes in very handy for. I think part of our job as the adult with CF is we're just going to, at this point, have to educate our PCPs as much as we can on this disease and use them for the resources we need to use them for, but know that we're really going to have to pick up most of the slack.
For me, I never wanted to have a PCP only because my experience with them has unfortunately been very poor, where they would kind of be overboard and think they know about CF, and then unfortunately it would prove wrong because they would either prescribe something that wasn't necessary, or they would forego something where I'm showing very obvious symptoms of decline, and they wouldn't treat it. And simple example is just last year I got a primary care because I have been hearing a lot of, you need a primary care, you need a primary care. And I've been resisting it, but I signed up and did my due diligence and went and saw one. And the minute one of the labs was off with my diabetes, she tried to jump in and change everything. And I said, no, you can't do that. I have an endocrinologist. I explained everything. Then there was, I've been having very bad situations with my bones. I'm now at osteoporosis. I'm being treated by my endocrinologist and my CF team, knowing that I can't take the oral medication, but the primary physician tried to get me on it and not listen to my CF team. So right now I am talking to you from the hospital, and I have to say, in absolute all honesty, it is horrific to the point of exhaustion to try to teach and educate someone who is outside of the CF sphere when you all are already sick and in decline, and when I'm just going to be brutally honest, when ego is involved and they don't want to step aside and listen to what you have to say because you've been living with CF for a long time, you understand your medicines, you understand your body. And when they want to go in and do something different, like yesterday they tried me on an antibiotic that I actually can't take. I'm resistant to it. But their answer was, well, we just want to cover you prophylactically. And I have to explain that's not how it works. So for me, it's been a very hard road dealing with primary physician. And I do come from middle school where CF docs dealt with everything, but now we're older, so we do have to try to step out of this box. And like Jen said, it requires an incredible amount of educating. And unfortunately, sometimes we're at their mercy when we're down and out, and it's a bad place to be.
If I could just add one more thing, it's not just the primary care. I deal with this also with my rheumatologist, who has absolutely very, very little knowledge of cystic fibrosis. So I run into that there. I run into it with my gynecologist. So there's all other areas that we need care, and we are there to first educate them. And this is how I now know that I'm with the right physician. If they are willing to listen and willing to learn, I'll stick with them.
Absolutely.
If they are dismissive or think, like Linda said, like they know it all, then I leave and I go find somebody else.
As we age and as modulators can't take care of everything, even younger population will have to deal with this at some point. That sphere of specialists will be harder to navigate those inroads to get them to understand CF and to just be a little bit more open-minded to the patient or the family, the caretaker, to hearing them.
Thank you both for sharing. I think that just illustrates the earlier call to action. As CF care teams, we have to make this process better for our community members, the families who are dealing with this, our adults with CF who are dealing with this on a regular basis. For the figure we have showing everything that happens in between visits, we have another one that shows everything that the community members have to do between visits. And so it's overwhelming. And so whatever we can do to develop those communication pathways back and forth between our essential partners and our trained and trusted referrals is only going to help to improve this whole process and hopefully translate to improved outcomes for our adults with CF and family members who are dealing with this with their children.
All right, I want to thank you all for coming. I want to thank all of our speakers, both here and away and afar. I'd like to invite all working group members to come up here as everyone else is leaving. So thank you all very much. Nicely done.